A calcium score can reveal something deeply unsettling. Calcium is supposed to strengthen your bones. So why is it showing up inside the arteries that supply your heart? And if you have been taking calcium or vitamin D for years, the question becomes even more uncomfortable. Did something meant to protect your bones somehow endanger your arteries? Before you stop a supplement, throw away your milk, or make any changes to your medication, stay with me, because that conclusion is usually wrong. The calcium in coronary plaque is not simply calcium from yesterday's tablet getting lost and sticking to an artery. Coronary calcium is part of a complex disease process involving cholesterol-rich plaque, inflammation, aging, kidney function, diabetes, smoking, blood pressure, and the biology of the artery wall. But your body does have proteins that help regulate inappropriate mineral buildup in blood vessels. Those proteins depend on one vitamin to function properly. That vitamin is vitamin K, and one particular part of the vitamin K family, vitamin K2, has become the focus of a surprisingly intense scientific debate. In this video, you are going to discover what vitamin K actually does inside the artery wall, why the popular claim that it directs calcium into your bones and away from your arteries is useful but incomplete, and what a recent randomized trial found after giving vitamin K2 to people who already had coronary calcium. The result was encouraging, but nowhere near as miraculous as supplement advertisements will tell you. And near the end, I will explain the one medication interaction that can turn a seemingly harmless vitamin into a serious safety problem. If you take warfarin, that section is not optional. But first, let us clear up the calcium mystery. Calcium in food is not the same as coronary calcium. When a scan detects coronary artery calcium, it is detecting calcified atherosclerotic plaque in the arteries supplying the heart. A higher calcium score generally indicates a greater burden of coronary atherosclerosis and a higher future cardiovascular risk. The score is not simply measuring how much calcium you recently ate, and it does not mean calcium has been pulled directly out of your bones and deposited in your heart arteries. That distinction matters because people often react to a calcium score by becoming afraid of dietary calcium. They stop eating yogurt. They abandon calcium prescribed for a genuine bone health reason. Some even stop medication without discussing it with the clinician who ordered the scan. Do not make that mistake. Your bloodstream keeps calcium within a tightly controlled range because calcium is essential for nerve signals, muscle contraction, blood clotting, and normal heart rhythm. Your bones act as a major calcium reservoir. But vascular calcification is not a simple plumbing accident in which extra calcium floats around and sticks wherever it lands. It is an active biological process. Cells inside diseased blood vessels can begin behaving in ways that resemble bone-forming cells. Inflammation, abnormal phosphate balance, kidney disease, oxidative stress, diabetes, and atherosclerosis can all contribute. So why does vitamin K enter this story? Because the body produces a protective protein inside blood vessel tissue called matrix GLA protein, usually shortened to MGP. MGP is considered an important natural inhibitor of vascular calcification, but when the protein is first produced, it is not fully functional. It needs vitamin K-dependent chemical activation before it can effectively participate in controlling mineralization. Here's the easiest way to picture it. Imagine the artery wall has a braking system designed to resist inappropriate mineral buildup. MGP is part of that braking system. Vitamin K does not magically vacuum calcium out of an artery. It helps activate the molecular brake. That difference may sound small, but medically it is enormous. A supplement can support a biological mechanism without necessarily reversing disease, preventing a heart attack, or extending life. Keep that distinction in mind, because it will become crucial when we reach the newest clinical trial. The second vitamin K-dependent protein. Vitamin K also helps activate osteocalcin, a protein involved in bone mineralization. That is where the popular idea comes from that vitamin K helps place calcium in bones while keeping it out of arteries. There is a real mechanism underneath that slogan, but the slogan makes the process sound far more direct and controllable than human biology actually is. Calcium is not loaded onto a delivery truck, driven away from an artery and deposited into your hip. Bone loss and vascular calcification frequently occur in the same older adult, But this does not prove that calcium is simply migrating from one location to the other. The conditions share many risk factors: aging, reduced physical activity, diabetes, smoking, kidney dysfunction, chronic inflammation, hormonal changes, poor nutrition. So the accurate statement is not vitamin K sends calcium to the right place. The accurate statement is vitamin K activates proteins involved in normal bone mineralization and in the inhibition of inappropriate vascular mineralization. That is less dramatic, but it is also true. If you appreciate health information that separates the real mechanism from the marketing version, tap like now. It tells the platform that evidence-based explanations are worth showing to more people. Now we need to answer the obvious question. If vitamin K activates these proteins, are most adults getting enough? That is where the story becomes complicated. Vitamin K is a family, not one single substance. Vitamin K exists in several forms. Vitamin K1, or phylloquinone, is found mainly in leafy green vegetables such as spinach, kale, broccoli, cabbage, and lettuce. Vitamin K2 refers to a group of compounds called menaquinones. Different menaquinones have different chain lengths, food sources, absorption patterns, and durations in the bloodstream. One form, receiving particular research attention, is menaquinone 7, commonly called MK7. MK7 is abundant in natto, a traditional Japanese fermented soybean food. Smaller and highly variable amounts of other vitamin K2 forms may be present in fermented foods, cheeses, eggs, meat, and dairy products. You will often hear that K1 goes only to the liver for clotting, while K2 travels to bones and arteries. That is too simplistic. K1 is strongly involved in activating clotting proteins in the liver, but it can also contribute to vitamin K functions elsewhere in the body. K2 forms may circulate differently, and some remain in the bloodstream longer. But the body does not divide the two forms into completely separate departments. The official adequate intake for total vitamin K is approximately 120 micrograms per day for adult men and 90 micrograms for adult women. Those values were established largely around maintaining normal coagulation because there is not enough evidence to establish a separate recommended intake specifically for preventing vascular calcification. That does not prove that the current intake is ideal for every extrahepatic vitamin K-dependent protein, but it also does not prove that everyone meeting the recommendation is secretly deficient. Clinically significant vitamin K deficiency is uncommon in generally healthy adults eating a varied diet. Risk can increase with fat, malabsorption disorders, severe illness, liver disease, prolonged poor intake, and certain medications. This is where many supplement videos go off the rails. They take an interesting biomarker, the amount of inactive MGP in the blood, and treat it as proof that nearly everyone needs a K2 supplement. It is not that simple. Inactive MGP can provide information about vitamin K status in tissues and is associated with vascular risk in some populations, particularly people with kidney disease. But a biomarker association does not automatically establish that. Giving a supplement will prevent cardiovascular events. To find that out, researchers have to perform randomized trials, and those trials have not all agreed. The evidence comes in 3 layers. To understand the K2 debate, separate the evidence into 3 levels. Level 1, the mechanism. Vitamin K is required for the activation of MGP. Active MGP participates in inhibiting vascular calcification. That biological foundation is strong. Level 2, observational research. Several population studies have found associations between higher dietary intake of certain vitamin K2 forms and lower cardiovascular risk or less vascular calcification. These findings are interesting, but observational studies cannot prove cause and effect. People who eat more of one food differ from other people in countless ways. They may exercise differently, have different income and healthcare access, smoke less, eat fewer processed foods, or have other lifestyle patterns that are difficult to measure perfectly. An association can generate a strong hypothesis, and it cannot settle the treatment question. Level 3, randomized trials. This is where researchers assign participants to receive vitamin K or a placebo and compare what happens. Some trials have improved biochemical markers showing greater MGP activation without producing a clear reduction in calcification. A previous randomized trial testing vitamin K2 together with vitamin D found no significant reduction in average coronary calcium progression over 2 years, although some subgroup findings generated further hypotheses. Trials in people with kidney disease, diabetes, or valvular calcification have also produced mixed or disappointing results. For years, the honest conclusion was the mechanism looked convincing, but the clinical imaging results were inconsistent. Then a newer trial added an important piece of evidence. Not the final answer, but a meaningful piece. What the new K2 trial actually found. Researchers studied people who already had established coronary artery disease and measurable coronary calcium. Participants were randomly assigned to receive either 360 micrograms of MK7 daily or a placebo for 2 years. The people receiving vitamin K2 experienced less progression of coronary calcium than the placebo group. That is encouraging. But now listen carefully, because nearly every word in the next section protects you from being misled. The calcium did not disappear. The arteries were not cleaned. The trial did not show that K2 prevented heart attacks. It did not show that K2 prevented strokes. It did not show that participants lived longer. It measured progression on coronary imaging. The study involved fewer than 200 people. The participants already had coronary disease and existing calcium. Many were using statins, and the researchers themselves characterized the clinical implications cautiously. The results suggest that MK7 may slow coronary calcium progression in a selected population. It does not prove that every adult over 60 should take it. It also does not establish whether slowing the calcium score translates into fewer cardiovascular events. That distinction matters because a calcium score is a risk marker, not the disease's entire story. Atherosclerotic plaque can contain calcium, cholesterol, inflammatory tissue, fibrous material, and other components. A calcium scan detects calcified plaque, but does not directly measure every form of non-calcified or potentially vulnerable plaque. And there is another complication. Statin therapy can sometimes increase plaque calcification or density while reducing cardiovascular risk, possibly because the plaque becomes more stable. This does not mean calcium is good. A higher overall calcium burden remains strongly associated with higher cardiovascular risk, but it does mean that interpreting changes in a calcium score is more complicated than saying less calcium always equals safer plaque. That is one reason researchers need outcome trials. A scan result can move in a promising direction while leaving the ultimate clinical question unanswered. Did fewer people have heart attacks, strokes, or cardiovascular deaths? We do not yet have that answer for routine K2 supplementation. Here is a useful checkpoint. Would you take a supplement because it changed a scan, even if researchers had not yet shown that it prevented a heart attack? Tell me in the comments. There is no perfect answer. The question reveals how differently people think about emerging evidence. What a coronary calcium score should actually change. If your calcium score is elevated, the most important response is not to hunt for a supplement that promises to erase it. The score should trigger a serious discussion about your overall cardiovascular risk. Depending on your score, age, symptoms, cholesterol, blood pressure, diabetes status, smoking history, and family history, your clinician may discuss cholesterol-lowering treatment, blood pressure control, smoking cessation, diabetes management, exercise, nutrition, weight management, further testing when clinically appropriate. A coronary calcium score is especially useful when a person's risk is uncertain, and the result could help guide preventive treatment decisions. Do not view the score as a stain you must scrub away. View it as evidence that atherosclerosis is present and that proven risk reduction measures deserve attention. Vitamin K2, at this point, is an emerging adjunct, not a replacement for standard cardiovascular prevention. Can food provide vitamin K2? Yes, although the amount varies widely. Natto is by far the most concentrated dietary source of MK7. A small serving can provide far more K2 than most Western diets contain. The problem is that natto has a strong flavor, smell, and sticky texture that many people do not enjoy. Certain fermented and aged cheeses contain menaquinones, but amounts vary with bacterial cultures, fermentation methods, manufacturing, and storage. Egg yolks, poultry, meat, and some dairy products can provide smaller amounts of particular K2 forms. The concentration can vary depending on animal feed and production practices. Leafy green vegetables remain excellent sources of vitamin K1 and should not be dismissed merely because a supplement company wants to sell K2. Greens also provide fiber, folate, potassium, carotenoids, and other compounds associated with cardiovascular health. This is important because a person could watch a K2 video and conclude that cheese and butter are artery-protecting foods, while vegetables are inadequate. That would be terrible nutrition advice. Some cheeses provide K2, but they may also contain substantial sodium and saturated fat. Butter may contain small amounts of K2, but it is not a cardiovascular treatment. Do not turn one micronutrient into permission to build an unhealthy overall diet. A heart-supportive pattern emphasizes vegetables, fruits, legumes, whole grains, nuts, fish when appropriate, and unsaturated fats, while limiting excessive sodium, highly processed foods, and excess saturated fat. A small portion of fermented cheese or an egg can fit within that pattern. They should not become the foundation of it. Vitamin K is fat-soluble, meaning dietary fat supports absorption, but this does not require adding large amounts of butter. A normal balanced meal containing healthy fat is sufficient. What about gut bacteria? Some intestinal bacteria produce menaquinones. However, researchers are still uncertain how much bacterially produced K2 contributes to a person's usable vitamin K status because the location of production and absorption matters. Prolonged antibiotic treatment can contribute to vitamin K problems in vulnerable individuals, particularly when combined with poor intake, illness, or malabsorption. But one course of antibiotics does not automatically mean your arteries have become deficient in K2. That is another example of a plausible mechanism being stretched far beyond the evidence. Should you take a K2 supplement? For most healthy adults, routine K2 supplementation to prevent or treat coronary calcification is not currently established as standard medical care. No major cardiovascular guideline recommends that everyone over 60 take K2 to prevent coronary disease. That does not mean the supplement has no potential. It means the evidence is not yet strong enough to guarantee meaningful cardiovascular benefit. People most likely to consider the discussion seriously include those with documented vascular calcification, osteoporosis concerns, restricted diets, malabsorption, or other medical factors. But even in those groups, the decision depends on medication use, kidney function, liver health, and the reason for supplementation. The form most commonly used in newer cardiovascular research is MK7. Commercial products frequently provide roughly 90 to 200 micrograms, while some research trials have used higher doses, including 360 micrograms. Do not interpret the absence of a formal upper intake limit as proof that any dose is universally appropriate. Supplements can contain inaccurate amounts, can interact with medication, and can create false confidence that allows proven treatments to be neglected. A person who takes K2 but continues smoking, ignores high LDL cholesterol, leaves blood pressure uncontrolled, and stops a prescribed statin has not protected their arteries. They have substituted a promising theory for established prevention. Save this section or send it to someone who is considering a K2 supplement because the safety issue coming next matters more than the brand or dose. The warfarin warning. If you take warfarin, also known by the brand name Coumadin, do not begin a vitamin K supplement without speaking to the clinician or anticoagulation service managing your treatment. Warfarin reduces the activity of vitamin K-dependent clotting factors. A sudden increase in vitamin K intake can reduce warfarin's anticoagulant effect and alter the INR. That could leave you less protected against the clot, stroke, pulmonary embolism, or other condition the medication was prescribed to prevent. The key principle for people taking warfarin is not necessarily zero the vitamin K. It is consistency. A person who regularly eats leafy greens may still be managed safely on warfarin when the intake remains reasonably consistent and the dose is adjusted accordingly. The danger often comes from sudden changes. Starting a high-dose K2 supplement, drinking concentrated green powders, or dramatically changing vegetable intake without notifying the anticoagulation team can destabilize treatment. Never stop warfarin in order to take K2. Never adjust warfarin yourself. And do not assume a supplement labeled bone health is irrelevant to your blood thinner. The newer direct oral anticoagulants, including apixaban and rivaroxaban, do not work through the same vitamin K pathway, but that does not make supplements automatically safe. Your clinician or pharmacist should still know everything you take. Other situations requiring extra caution include fat malabsorption disorders, significant liver disease, kidney disease, use of bile acid sequestrants, use of medications that interfere with fat absorption, multiple prescription medicines, planned surgery. This is the CTA that matters most in the entire video. If someone you know takes warfarin, share this warning with them before they buy a K2 supplement. What about vitamin D and calcium? You may have heard that taking vitamin D without K2 is dangerous because vitamin D absorbs calcium and K2 is required to direct it. That statement is heavily promoted online. The biology is more complicated. Vitamin D helps regulate calcium absorption and influences the production of several proteins involved in mineral metabolism. Vitamin K activates particular proteins through carboxylation. The nutrients interact within the same broad biological system, but there is not strong evidence that every person taking ordinary vitamin D must automatically add K2 to prevent artery calcification. Do not begin K2 out of fear that your vitamin D is poisoning your arteries. And do not stop vitamin D prescribed for a documented deficiency without medical guidance. The same applies to calcium. Dietary calcium is important for bone health. Calcium supplements may be appropriate for selected people who cannot meet needs through food, or who have specific osteoporosis-related recommendations. The relationship between calcium supplements and cardiovascular risk remains debated and may depend on dose, total intake, and patient factors. The correct response is not calcium is dangerous. The correct response is to review why you are taking it, how much calcium you receive from food, whether the supplemental dose is necessary, and how it fits with your personal bone and cardiovascular risks. Your pharmacist or clinician can help reconcile vitamin D, calcium, K2, osteoporosis treatment, kidney function, and cardiovascular prevention. That is far safer than assembling a supplement stack from separate internet videos. The interventions with the strongest evidence. This may be the most important part of the entire discussion. If your goal is to reduce your risk of heart attack and stroke, the most proven actions are not mysterious. Ask 3 questions. Does this interact with any of my medications? Is there evidence that I personally need it? And what proven heart treatment must I not neglect while considering it? If you take warfarin, do not start it without professional guidance. And if you have a high coronary calcium score, use that information for what it does best to build a more serious, personalized cardiovascular prevention plan. The aim is not to win a smaller number on a scan. The aim is fewer heart attacks, fewer strokes, and more healthy years. If this video helped you understand the difference between a real biological mechanism and a proven medical outcome, subscribe. In the next video, we will examine another widely promoted artery clearing claim and separate what has actually been demonstrated from what is still marketing